Here at the 2014 Chest Conference in Austin, Texas, always a pleasure to have with us Dr. Val McLaughlin from the University of Michigan. Thank you for being here.
Hi Tom, thanks for having me.
So you moderated a session in scientific sessions on updates from the 5th World Symposium on PAH. What can you tell us about that?
Oh, it was a great session. We had a number of experts speak on some of the different symposia that were in that session, including the updates in the classification, the updated diagnostic algorithm, the therapy, the treatment algorithm, and an update on the pediatrics task force.
What do you feel are the essential modifications of the goals of PAH treatment coming out of the 5th World Symposium?
Well, Tom, we had an entire task force on goals of therapy, really trying to elevate the bar, trying to get our patients optimally treated, because we have learned a number of indices that correlate with prognosis. So some of the goals for treatment that we have now are to improve patients to functional class 1 or 2 status. Observational studies are all consistent, showing that if we get patients to functional class 1 or 2, they're going to do better. Another important determinant of outcome is function of the right ventricle. If we can improve the function of the right ventricle, the patients will do better. And we follow this by either imaging with echo or MRI, or by measuring cardiac output and right atrial pressure at the time of cardiac catheterization. One measure that we often follow, 6-minute hall walk, was actually downgraded a little bit. Some of the cut points for that may not be aggressive enough, especially for young individuals. And other things like NT-proBNP or BNP, trying to get those levels to normal will show us that the stress on the heart is reduced. And again, observational trials have shown that no matter what therapy you use, if we can get patients to those goals, they're going to do better in the long time. And sometimes that requires escalation of care and more than one therapy.
How do those task force work? There must be a lot of really good give and take and exchange of ideas.
Yeah, well, the task force they're really a lot of work, actually. It's not like you just come to the meeting and you sit in a room and talk. Before the meeting, each member of the task force is given a topic to review, and they review the literature and really write a report on that particular item so that we have the evidence base for discussion. And at least on the goals of therapy task force, we divided up everything that has ever been considered a goal, had people do the research, the literature searches, and make some recommendations, which then as a task force we discuss to come up with the final recommendations.
Okay. What studies or procedures should be performed in serial follow-up to monitor patients with PAH in hopes of achieving the treatment goals?
Tom, this is a really critical question, because this is how we improve outcomes in patients, by achieving the goals. It's all well and good to make a correct diagnosis of PAH and start a therapy, but oftentimes patients are going to need more than one therapy to achieve the goal, so you need to follow them closely. In general, many patients are followed every 3 months or so. If they're sicker, they may be followed even more frequently, especially at the beginning. And some of the easy tests to repeat include a 6-minute hall walk or a clinician's assessment of functional class, the blood draw for BNP. We get echoes and right heart caths, not at every clinic visit, but certainly in newly diagnosed patients, we may get an echo at 6 to 12 months and a right heart cath at 6 to 12 months to see if we've achieved these goals. So what you want to see is that the patient improves on therapy, improves to functional class 1 or 2 with a good hall walk, and that needs to be taken into account with their age. A younger person, 400, 450 may not be enough. And then you want to see the RV function improve, be it on echo or by cardiac output, right atrial pressure at the time of heart catheterization. And if they don't meet those goals, you need to escalate therapy. Now, a lot of practices feel very comfortable escalating therapy when it comes to oral drugs, putting a patient on a PDE5 inhibitor and an ERA. But you have to keep in mind that if a patient doesn't achieve goals on oral therapy, we have the whole class of prostanoids that really can get patients where they need to be. And that's often where we find the reluctance, because of the cumbersome nature of some of those therapies, because of the side effects. But you always need to weigh that with really getting the patient to their treatment goals and improving their long-term prognosis from PAH.
What do you feel drives reluctance of physicians to advance patients to the most aggressive therapies?
Yeah, so these aggressive therapies, they're foreign to some physicians. Sometimes patients are practicing in settings where they don't have the nursing support to dose titrate a prostacyclin. Sometimes they're not familiar with the pumps or if they don't have experience with those therapies, it just seems overwhelming. You think about the side effects, but you don't really appreciate how much better patients can get. It's a really critical issue because in many studies now we have found that 40% or so, sometimes even more, of patients who still have functional class 3 and 4 symptoms on oral therapies don't get escalated to a prostacyclin.
Thanks for stopping by. I know it's a busy conference for you. Appreciate your time.
Oh, my pleasure.